I went into nursing to, it's the stereotypical to help people, right? But as I've been in my career and as I've worked in, for the past 6 years, the biggest thing about nursing that I love is really getting to know my patients. Learning from them. Like especially in oncology, they have taught me so much about life and about the value, what really matters in life, right? Um, when you're hit with a disease as brutal as cancer, it forces you to come face to face, to confront your mortality, maybe for the first time in your life, right? And as a result, patients have really, like learned to live life to the fullest, and to never take, life for granted. And I've kind of adopted those lessons myself.
Hi, everyone. Welcome to MDF Instruments Crafting Wellness
Yeah,
Podcast.
my name is Em, aka the Spitfire Nurse, on Instagram. I am an oncology palliative care nurse. So I've been an oncology nurse for about 6 years now, and I've been in palliative care for the past two. I work closely with oncology patients in the outpatient setting, and I'm based out of Houston, Texas.
We really are excited to kind of dive into what you do because you're in a bit of a niche field, I think, and in a field that maybe doesn't have a big light shining on it as far as what you do and how you help patients. And I know there is some misinformation sometimes, even in the medical field itself. Can you kind of just walk us through what palliative care is and oncology nursing and what you kind of do, what your day-to-day life is like as a nurse?
So palliative care is actually a very unique specialty. Like I said, there's a lot of misinformation, but what palliative care is a service dedicated to symptom management and dedicated to optimizing quality of life. In the oncology patient population, palliative care and oncology run hand in hand because, we want to make sure that our patients who are undergoing these pretty brutal treatments on their cancer itself are able to get through, their treatments and able to live normal lives. Cancer is one of those it's a very destabilizing disease and it throws people off, right? So our job in palliative care is to make sure that they are able to live as normal life as possible while still having cancer. Oncology it's kind of funny. I mean, I always say I didn't think I was going to end up in oncology nursing, but now I can't see myself leaving. I took a chance kind of when I was in my final semester of nursing school, just because I didn't think I had the heart to work with oncology patients. It's a very special patient population. They're very vulnerable, but at the same time, very strong patient population. So I took a chance. I started working on an inpatient unit right out of nursing school, and I fell in love with it. Done inpatient, I've done infusion, and now I work in a clinic where I combine oncology and palliative care nursing, which is my true passion. And I do a lot of education about palliative care. As you said, there's a lot of misinformation about it, even among healthcare providers. People tend to confuse it with hospice, which, palliative care is an umbrella term that includes hospice, but they're not interchangeable terms. And I think that patients, there's are afraid of hospice and are afraid of, because they associate hospice with dying, when really, hospice is about making sure that you are comfortable, as you pass, which, as healthcare workers, we can't really, that's what we want. We want when our patients are dying or, in that final stage of life, we want to make sure that it's as peaceful as possible. So my day-to-day life now is I kind of have the best job. I work 5 days a week, sometimes 4 days a week. No weekends, no nights, no holidays. That's exactly the way I like it. I actually do a lot of telemedicine, which is interesting. I didn't think that that was going to be what I did when I accepted this job, but I really like telemedicine. It kind of forces you to kind of step outside your comfort zone when you're assessing patients because you can't physically lay your hands on them. But for these patients who are struggling with symptoms, sometimes, fatigue being the biggest one, they're not able to come into the clinic because they're just so wiped out or they're in such bad pain that they can barely get out of bed. It's helpful for us to be able to provide this service for them so we can still see them and we can still, give them the care that they so desperately need without putting them at risk for falling when they come into the clinic. So that's kind of what my day looks like. And I've been doing that for the past 2 years. And again, I can't see myself doing anything differently. I love it.
That's awesome. I know you're really passionate about it. I love watching all of the content you make. You educate about what palliative care is, oncology nursing. You talk about symptoms of cancer. I mean, you really run the gamut. Anybody can find your content purposeful, whether you're in the field, medical field or not, because you really do give some education and some advice on things to look out for. And you talk a lot about, I know insurance is a big thing, and all kinds of battles that you as a nurse are constantly fighting that aren't just about the patient. Sometimes you have to fight the insurance company to be able to get help to the patient. And so really are kind of fighting a lot of battles that people don't always see.
Insurance, and when you're in nursing school, they kind of touch on it, but they don't really tell you how much, how big of a grip insurance companies have on healthcare. And I just created a video about this, about the things they don't teach you in nursing school. And honestly, it's really kind of disheartening to see, insurance companies deny these life treatments for patients. I've spent hours, countless hours on the phone with insurance companies battling for patients, all behind the scenes. And meanwhile, patients are, either they get mad at us, at the team, because they're like, why isn't my med approved? And I was like, if you could only see how many hours I've spent fighting for you. And a lot of them, especially in oncology, because these cancer drugs are very, very, very expensive. And even some of the medications that we give to help manage their symptoms can be very expensive as well. So they're kind of aware with, of the process. They know how insurance works, and, how, the propensity for insurance companies to deny their treatments. So that's it's helpful in that end, but it's also disheartening because you want to do your best to help your patient, and sometimes even when you do everything right, you'll hit that roadblock at the end that always has to do with dollar signs, and you're kind of helpless. And I've lost a few patients because they weren't able to get the treatments that they needed because they couldn't afford their treatment. And even if insurance does cover it, co-pays for these medications can be incredibly high as well, and patients will bankrupt themselves. And it's devastating. And it's one of the dark sides of healthcare that you really, again, don't learn about in school, or don't learn about enough. So yeah, it's unfortunate.
Yeah, that has to be frustrating as a nurse who's there trying to do everything you can. If a patient can't be saved, obviously you're doing your best, working with the rest of the medical team to try to save a patient. I mean, obviously that's first priority, but sometimes, it is terminal. There isn't a lot you can do except make the patient comfortable. You talk about that a little bit, as that is what palliative care is helping the patient manage their symptoms, making their life as most comfortable as possible. And that's not just physical and it can be emotional as well, mental as well. I know the care kind of spreads throughout all of those ways. But as a nurse, trying to fight and protect and save and help and do all of these things, that has to be one of the most frustrating things to watch, is when you know that you can alleviate some symptoms or help in a way, but you just can't into the patient because of financial restrictions, or the insurance isn't going to cover it, or the patient can't afford it. And that's really it's really a sad thing to see, that money is the thing that even at the end of life is going to decide if you can really have the care that you as a nurse would want to give to everyone.
Well, you realize very quickly when you enter healthcare that healthcare is business, right? And businesses can't run without money. So as much as we want to do, the best for our patients, sometimes again we're very limited. These limitations that I've run into are not just financial. A lot of them are, but you know, with palliative care, right? It's one of those fields that's controversial even among healthcare providers, right? Patient healthcare providers are educated. Obviously, we all go to school. We all learn about what palliative care is, but healthcare providers are still resistant to consult us. And I think it's twofold. One, like just the healthcare model. People want, especially providers, are trained to help patients, right? To always try to cure them. It's like the medical model. So when they palliative care, they associate palliative care with hospice and giving up, right? They don't want to give up on the patient. And the same thing with a patient perspective, right? A patient doesn't want to, they think palliative care, they think hospice, and they think, oh, I don't want to give up because it's not, this is, I don't want to die, right? When in reality, it's it's very, hospice is end of life, obviously. Like, you have to have a certain qualifications, 6 months to live. That is the biggest one. But with palliative care, anyone with a complex disease can qualify for palliative care, and cancer is one of them. In an ideal world, in my head, everyone who is diagnosed with cancer should immediately have a palliative care consult, because we are there to help the whole patient, right? Physical symptoms, psychological ones, spiritual ones. That is our game, right? We are here to help you get through one of the worst parts of your life, right? Cancer is a terrible disease, and it has, ripple effects, physical effects, and especially, mental ones and emotional ones. It affects not just the patient, it affects the family as well. And we are in palliative care, we're here to help the whole unit, right? We want our patients to succeed, with as little symptom burden as possible. And no, like, offense to my oncology colleagues, right? I worked in oncology, so I know, what, and I worked in the clinic as well. But, the they tend to focus more on physical symptoms, just because, the patient will come in, they'll do an assessment on them to make sure that the chemo, they're cleared to receive their treatment. But it's kind of, they don't really have time to address the mental health, burden that cancer can cause. And that's kind of where we come in, right? We're our appointments are longer, and we're really there to sit down with the patient and just literally just say, hey, tell me what's going on, right? And we have a certain set of symptoms that we go through, and anxiety and depression are two of the big ones that we assess, and then we actually have time to assess and really go in depth into. And a lot of patients find it very, I think, relieving. They're able to talk about it. I've seen even the strongest of men crumble, and just open up. And I think that is something that's super rewarding as a nurse, to be able to break, patients, have patients trust you enough to open up and tell you about all the things that they've been bottling up inside, right? They don't want to burden their family with all the sadness that they're having. But once they finally get it out, they feel better. So that's definitely one of the best parts of my job, I think.
When you're battling something as difficult and serious as a cancer diagnosis, I feel like a big part of that battle is mental, because you have to have the optimism, the will to fight. And sometimes I think, your brain is a very powerful thing. And if you give up on yourself because you're depressed and sad and you're like, this is it for me, then your body is going to kind of follow suit. And it's one of those things, if you can have the mental strength and fortitude to say, you know what, I know I don't feel like eating. I'm nauseous. I can't keep any food down. There's no point. I don't want to. But like having that mental fight to live, and that will, it will get you through those moments. I know I can't survive. I can't fight this cancer without nutrition. And that was a big thing with my father, who had prostate cancer, was he had no appetite. After radiation, after chemo, no appetite. And his weight just kept going low, 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 low. And it was causing anxiety in me watching the scale go down, because I'm like, well, how far until we're worried? Like, how far, like, how much weight can he lose before we're concerned about this? And I got fought with a little bit of like the mental anguish that that puts on a patient, of the extra stress of like, they see the weight coming off too, and you like don't want to scare them, but at the same time it's like, okay, but at what point do we want to say something? Because so I did have that kind of fight of, because as his daughter, I wanted to say, Dad, you need to eat, like, let's get, and so you don't really always know what the right thing to do is. But the the mental anguish that the families go through and the patient goes through, I think having palliative care and people who are experienced, who have seen countless different people and run the gamut of different kinds of cancers and different ages and different sexes and all different walks of life and everything, that you guys are the ones that kind of have that knowledge and experience to say, okay, here's how we can handle this in a way that's going to be conducive to the healing of this person, or is going to make this less stressful for them and less anxiety. Then you're actually bringing more to your dad than you want, then you're hurting him more than you're helping him because he can't eat, it's not his fault. So I think there's definitely that like push pull situation. And I can imagine that family members also find you guys very helpful and useful when they're looking for how to also help their family member go through the hardest, most battle of their lives.
Yeah, I mean, it's funny you bring up appetite because that is probably one of the most concerning symptoms for families, right? But it's such a multifaceted symptom. There's multiple things that could be causing loss of appetite. Physical, obviously, being does the patient have an obstruction? Are they nauseous? But there's also, like you said, the mental health aspect, right? Patients who are depressed and who may not know that they're depressed, loss of appetite is a symptom of depression, right? So being able to sit down with patients and really kind of dig deep and be like, okay, tell me really what's going on, right? Because patients be like, yeah, I just don't know why I'm not eating, and I'm like, okay, and then like you find you get to know them, and it may take a session or two, but you really come to realize, okay, this patient is beating themselves up, right? They feel like a burden on their family, and as a result, they just feel that's causing depression, and that depression is preventing them from eating. And I think families have a hard time as well seeing patients not eat. I think we're diet nutrition, where it's part of our daily life, and cancer can alter that greatly, right? Whether it's causing nausea or whether it's causing lack of taste, right? Can't like chemotherapy wrecks taste buds, and can make food just taste awful. So it can be hard to eat. And I've seen patients being like, yeah, I force myself to eat because I know I have to, or because I know my sister who lives with me wants, I don't want her to make, to feel bad. There is, like you said, there is a definitely like a threshold where we're like, okay, we need to do something, right? Like if the patient is losing an insane amount of weight, and the reason weight is so important is because treatments are based on weight. So if a patient loses, what we 10% of their starting weight initially when we make their treatment plan, that the chemotherapy plan has to be altered because it's not safe to give it. But it's it's one of those things where it can be that it's quantifiable. So when a patient's like, yeah, my appetite's better, and like everyone they're like, I'm eating, and their family's like, I'm eating, they're eating, and it makes them feel great. um but oftentimes there'll be times where the patient's like, I'm just forcing myself, and I feel bad, but I don't want to tell, like it hurts it physically hurts to eat. So I'll bring in the family member, and we'll have a sit down where just converse and be like, look, what was normal for them back then is not normal for them now, right? Their stomach is shrinking, they're not able to tolerate this, or maybe just food just tastes so bad that it goes, makes them want to throw up. Like you can't change that, and forcing them to eat and make just because it makes it's something that makes you feel better as a family member is not conducive here. So we do have these conversations all the time. Appetite is just one of them, but with family members, so they can kind of put things in perspective, because they're used to their normal, right, with the patient, but that normal is different now with cancer. So um, it's difficult. And I have no problem being the bad person and being like, like this is what we need to do, right? And so the patient doesn't feel like they have to cause create conflict among their family, because they really need them. As you probably know with your dad, no one cancer is not a solo disease. It takes a village. And patients who have support from their families tend to do a lot better than patients who are alone. So,
Yeah, and nurses like you who advocate for their patient. I mean, you are the liaison, you're the communicator between, the patient and their family to kind of help set the tone of what the expectation is. Because, if you've never experienced cancer before and you have no idea, you really don't know these things until you're walking through it. And so what you do is extremely helpful. My question is, how do patients come and find you? How does one come to find palliative care?
So most of the time, the majority of the time, it's the provider referring the patient and telling them, okay, like, I think, your nausea is getting out of control, your pain is getting out of control. I think we need to refer you to a team that can better manage this. It's very rare that a patient will request palliative care services. And that's kind of what I do on social media is I try to educate patients to be like, okay, if you're struggling, you ask your provider. They don't. Cancer is just one of the myriad diseases that palliative care can benefit, but ask your provider. Right. At worst, they'll say like, I think, I think your symptoms are pretty controlled right now, but um, I don't think it's time to refer. In which case, that's a different conversation, right? But most of the time, they'll be like, yeah, of course, like let's get you to see them. There's no harm done in seeing us, right? It's not giving up. We're not here to talk about hospice, right? We're not here to talk about end of life. We're here to talk about how can we make the symptom that you're struggling with right now better. And a lot of the times in oncology, the biggest symptom that we get referred for is pain. If the cancer is not getting treated, or if the cancer, is not responding to diseases, that pain will get worse. And there's a point where providers are not comfortable prescribing, medications like, high dose pain medications for these patients. But our team specializes in that, right? We do pain and we manage pain very, very well. It's like some hospitals don't have palliative care teams. I work at a very large cancer institution that does have a very, a long established palliative care team, but there are smaller ones that don't. But there are community palliative care teams that are available as well. So even if the hospital doesn't have it, they'll be like, let me put in a referral to case management to see if we can get you connected with a palliative care team or even a pain team, right? There's chronic pain teams all over the country that are, outside of the hospital. Comes from the provider and the health, as healthcare providers, I certainly think that we need to do better about, referring patients early to palliative care and not just when their symptom is so uncontrolled that, maybe we don't even have any options in palliative care to help them, right? Or the classic that we get is this patient is, there are no more no more treatments available. We need to talk about goals of care, right? I'm like, how would you feel, right, if you were getting referred to a team and they talk to you about how about code status, about sensitive topics like goals of care for the first time without ever having met them, right? You're like, why, who is this person, right? And we get a lot of pushback from patients too, because they're like, I didn't even know I was referred for this appointment. I don't know what this appointment is. And I'm like, I'm sorry, your doctor didn't, or your provider didn't tell you, right? You have a right to, complete transparency. Um, so it's healthcare providers 100% need to do better. They need to be more open. They need to communicate better with their patients. Let them know what the consult is is for, and let them know that maybe and consult way earlier. I tend to find that when these goals of care conversations do have to happen, and they happen more often than not in oncology, that if the patient's already established with us and they trust us, those conversations are a lot easier to have.
Yeah, and so there's no wonder that there's a confusion with palliative care and hospice. If the referral is coming so late down the line, then it might seem to people, oh, palliative care and hospice are like my options. I could understand how the confusion would happen if the referrals are coming in so late and there's not so much palliative care you can even do at that point because they're pretty much talking end of death wishes and do we resuscitate you and like all of that stuff. Is it true that um it's not just for cancer? Like palliative care can be for, I think you said COPD and some other things like that, but you personally just are an oncology palliative nurse. Is that right?
That's correct. Yeah. In order in order to qualify for palliative services, a patient has to have a complex disease, right? So basically, a disease that requires multimodal management. So COPD, heart failure, dementia, Alzheimer's, all of those are classic complex diseases, right? And I love palliative care. I've always kind of been passionate about it, but my floor that I started on had both oncology service and palliative care service running hand in hand. So I kind of got that exposure early, which is kind of what led me to where I am now. Um, but yeah, I'm a palliative care nurse and I only work with oncology patients. And I love my oncology patient population. So I think as much as I love palliative care, I don't think I would work outside of my oncology patient population, just because I have a close knit relationship with those kind of patients.
Yeah, I can see that. I have a few other questions about. I know that you go over this on social a bit, but could you just give us a kind of a cliff note version of the difference between palliative care and hospice? Because I know that as you spoke earlier in this podcast about how with hospice you have to have basically you have 6 months or less to live, approximately. No one can really tell you, but approximately. So there are certain things that differentiate between hospice and palliative care and why there's a confusion between the two. Could you just kind of give us a little, kind of tell us the differences between the two?
Of course, palliative care is the general is the big term, right? It actually includes hospice, but palliative care is symptom management, right? That is the focus of palliative care. Pretty much optimization of quality of life, right? Quality over quantity. You don't have to have, like I said, just have to have a complex illness. You don't have to be dying, right? You can be diagnosed, you can be referred to palliative care service at time of diagnosis. Um, Whereas hospice, you have to have a life expectancy of 6 months or less. That has to be diagnosed by a hospice qualified physician. And then you also have to give up all like treatment with curative intent. So you can still pursue palliative treatments, right? So, for example, like palliative radiation to help with pain in the spine, right? You can still do that, but you just can't do anything that might cure your disease. Palliative care, you certainly can. We walk hand in hand with oncology teams. We try to get patients through their treatment to achieve remission, right? That is kind of the thinking behind palliative care in the oncology setting. Um, but hospice, yeah, you can't pursue any curative treatments. However, hospice is not binding, right? So a patient has the right to revoke hospice at any time, right? And if they live past 6 months, they also, it's not like they'll automatically come out of hospice, right? Every couple of months or so, you have, a hospice provider who goes out and recertifies hospice, right? If they still think like that the patient still has a life-limiting disease, that they're going, they can recertify. So that's kind of the main difference between hospice and palliative care.
A place where you can go to manage all of your symptoms to help fight while you also pursue a cure or getting better. Whereas with hospice, you really can't do any life altering things to get the cure. Like you can't go get a tracheotomy or, they don't do treatments like that. They let you could probably eat and like normal pain meds and stuff like that in hospice, but they're not doing anything to interact with what is naturally happening with your body. Whereas palliative care is a great, as you say, it's the big umbrella, which is, hey, come over here, let us help you manage your symptoms, let us help you mentally, physically, emotionally, let us help manage your pain, and help, maybe counsel your family and let you like lessen expectations here for what they should expect you to be doing because things are different for you now, and really kind of work hand in hand with, I would think, their medical provider to just kind of alleviate those symptoms. And in a way, I think you're kind of alleviating some of the burden from the medical provider, who's probably also overwhelmed because they have a lot of other patients and that's not necessarily their specialty. Whereas you're in the specialty of palliative care and oncology. So you're going to be specifically able to meet their needs in a way that maybe the medical provider just can't do.
I could not have said it better myself.
Perfect. Okay, so what, um, for you as a nurse, what is something I want to hear what you love most about being a nurse. I want to hear what you wish could change about what you do in the nursing industry. I want to hear what you wish people knew about what you do or how other people can help spread awareness or make your job easier. And I kind of just want to talk a little bit about life for you as a nurse and kind of use the time to express what you would like the world to know as you are in such a unique situation a lot of times with what you do, and you are obviously very passionate, and I know that that can also take a toll on you as you are only human. So I'd love to hear a little bit about that.
Um, certainly, you know, I went into nursing to, it's the stereotypical to help people, right? But as I've been in my career and as I've worked in, for the past 6 years, the biggest thing about nursing that I love is really getting to know my patients. Learning from them. Like especially in oncology, they have taught me so much about life and about the value, what really matters in life, right? Um, when you're hit with a disease as brutal as cancer, it forces you to come face to face, to confront your mortality, maybe for the first time in your life, right? And as a result, patients have really, like learned to live life to the fullest, and to never take, life for granted. And I've kind of adopted those lessons myself. I'm thinking about this one patient I have, and he's fantastic. He has metastatic cancer, but he is the most optimistic patients that I know. And he said, there's no use in dwelling on something that I can't control, right? I can only focus on the future and trying to make myself better, for both me and my family. And I've adopted that mantra. You focusing on the past is not helpful. And remaining in the present, and even focusing on the future, right? Because you don't know what the future holds. But focusing on the present, on what is happening here and now, and really truly living in the present is the best thing that you can do for yourself and for your mental health. Oddly enough, I thought I wanted to be an ICU nurse, and I thought I wanted to be a CRNA, and I would have made a horrific ICU nurse or CRNA because I like talking to my patients. That's my favorite part of my job, which is why, telemedicine is perfect. Or even being in the clinic and talking to my patients face to face, I learned so much about them. They learn so much about me. We develop these relationships. I know all of my patients by name. And I love being able to do that, right? I see them all the time. I see them once a month. And I've developed, like friendships with a lot of these patients. And it makes it hard because obviously I know that some of them are not going to do well. And I've lost quite a few patients that I've been very, very close with. And that is one of the worst parts of the job. Especially in oncology, because you know that that's going to happen, right? You know that cancer is terminal. It can be terminal. Um, so you try to kind of, do your best for these patients and keep your distance, but sometimes it's just personalities click and you become really close.
How do you take care of yourself? Because obviously you're going to get attached. You care about your patients, you're very passionate, and sometimes you're seeing them from months and months and months, maybe even years, while they fight this fight. And I know that, like you said, not all of them are going to make it. And how do you take care of your mental health and your I don't know, I guess just your mental health mostly, because your emotional well-being, because I know that for me, I mean, obviously I don't have experience like you, but there's a certain empathy that I also have where it's so hard to watch. And I know that like you have to do it and you have to keep going. Like you could lose two patients in a day and find that information out, and you have to keep going. You've got another appointment where you have to like go help somebody, and it's a completely different scenario, and you got to put that smile on and be optimistic and help them fight that fight. So how do you do that?
Um, so two things really that kind of help me get through. Number one is I am an expert compartmentalizer. So what that looks like is that, when I clock in for work, I'm there, right? I am 200% available for my patients. But when I clock out, I I check out, right? I really, unless there's something that's really like, I had a really hard day, like I'll allow myself, I call my boyfriend in the car on my way home. I have maybe 20, 30, like 20-minute commute on the way home. And at that time, I'll kind of decompress. But when I walk into my house is a safe space. I do not talk about my job at my house when I'm home because for me, I need to have a place that I can retreat to and that I don't associate with my job. So that really, really helps because, like you said, it can be difficult, to dwell on these things. But it's the way I protect myself. It's been a protective mechanism since I started nursing. And it's really, really helped me deal with some of the rougher days that I've had. The other thing is I talk about this a lot, is, the way I view death in the oncology patient population, right? When I first started nursing, my preceptor on my inpatient floor told me that, death is a release for these patients, right? A release from the suffering, the endless suffering that they've been dealing with with cancer. Inpatient, we dealt with a lot of, patients don't get admitted for symptom burden unless it's really bad, right? And it can't be handled outpatient. So, when we had a patient pass inpatient, it was because, like it was peaceful. And that perspective on death and that was happened like literally my first month of nursing. And I've been a nurse for 6 years now. So that perspective alone has really helped shift my perspective. And, it's sad. And like, of course, like, I feel sad for the patients' families who may not have this kind of, this perspective. But for the patient, I know I'm happy that they're no longer suffering and that they're able to be relieved of these physical burdens, even mental burdens that they've been dealing with for sometimes years. That really helps me get through. And my roommate is a nurse as well. She's my best friend. She's a pediatric oncology nurse, so she deals with the same thing I do, but with kids. And she kind of does the same thing. She's also, a palliative care nurse, and she loves what she does. And it's really truly inspiring to see her do, everything because a lot of my patients when they pass, they've lived a good life, right? 50, 60, 70 years, 80 plus years. But for my roommate, she loses infants, she loses patients who are barely get the chance to live. But she does it with such grace. And she really loves her job. And a lot of actually it's to the point now where a lot of other nurses and even providers go to her for advice on how to deal, with death and dying in that patient population. And that's truly, it's a spectacle. And it's testament to her, her character as a nurse. And then finally, obviously, I surround myself with supportive friends and family. I don't I I don't keep anything in. I have a psychiatrist that I love. I used to go through therapy. I think that talking and getting your emotions out is the best thing to do, especially in a field as difficult as nursing. Um, and I was medication, same thing. I'm not ashamed. I'll never be ashamed of, pursuing treatment for my own mental health. I don't think any nurse doesn't, I don't know any nurse doesn't have a little bit of anxiety. It's the job. It comes with the job. But I'm a big believer in, in talk therapy, and making sure that you keep your emotions in check and you're aware of them. So if that means, talking to a therapist, that means talking to my friends and family. I have a very supportive, parents, very supportive boyfriend, and obviously I have my best friend. And that really helps as well.
And just to kind of add on to that, I was having personally for my experience with cancer, my dad with prostate cancer, it was really rough because he was in the ICU for 2 months and every 3 days would be a new doctor. And so towards the end, in the second month, a new doctor would come and that doctor would say, your dad there's a difference between saving life and prolonging death. And then we would all prepare to take him off life support. And then a new doctor would come in for the next 3 days. And then they would say, no, actually, we should try a tracheotomy so he can get fed or, whatever it was. And so there was a lot of like back and forth, back and forth. And it was it was horrific to go through because you go from thinking like 1 minute, okay, I'm going to lose my dad today to, okay, actually we're going to try treatment. Maybe we can help him. And it was a lot of yo-yoing around. And of course the hospital was very apologetic. But we wanted to do our due diligence as a family to make sure we are doing everything we could to to save him or help him or make things easier for him. And but that sentence that doctor said, there's a difference between saving a life and prolonging death. And that is the thing I think that finally got my family to the point where we're like, it's time to say goodbye. There's nothing more we can do. And it's really funny because my father hated hospitals, hated them. And he never wanted to, like, even when he really needed to go into the hospital, he would refuse. Like, he'd be like, do not put me in the hospital. Like, I'm going to be fine. And so when he was battling cancer. And so when he was obviously unconscious, he was on life support. He had a tracheotomy. He had tubes like everywhere that you could think of to have tubes. And they're like, we decided, okay, we're going to take him off life support. And it was expressed, okay, it could take a couple hours. It could take, a little longer. It could take 18 hours, but he's not breathing very well, like on his own. So we think that it won't take that long. And hospice wasn't an option because they didn't believe he was strong enough to take the trip to hospice. They were worried about him passing in transit, which they don't want to do. So we were like, okay, well, 1 day goes by, 2 days, 3 days go by. My dad starts doing better off of life support. His vitals are up. His all of his fluids, like everything was just improving. So much so that on like day 4, hospice said, you know what, we think that he's well enough, we can transport him to hospice. So he got to hospice, and the next morning he passed in hospice. And one of the last things my dad said to me was, I don't think I'm going to make it out of here. I love you. He told me that in the hospital in ICU. And when he got into hospice, I was like, Dad, you're wrong. You did get out. You got out, and he passed in hospice. And I was so thankful for hospice because it was such a beautiful space. My dad hated hospital. It was quiet. He had his own room. It was comforting to the family. There was more space and high ceilings. And it was just a really beautiful place. But I think that my dad was waiting for us to get him to hospice so that he could peacefully say goodbye. And my dad, he was a pilot his whole life, so aviator, and he died on August 19th, which was National Aviation Day.
Wow.
So sometimes you just have to say, you know what? There's nothing sometimes we can do as people. Like sometimes when it's someone's time to go, it's their time to go. But the best thing that we can do is comfort them and advise them and try to help them pass as peacefully as possible. And that's why I love so much what you do. And the fact that I had an opportunity to talk to you before a lot of that happened with my father. But I just think it's really important perspective to have because yeah, you might lose the patient in the end, but the care that you're giving through the process of that is invaluable to the patient and also to the family because that brings so much comfort. Like I don't even have words to express how much comfort when we had great nurses helping us. The burden of like the worry of like leaving my dad for a couple hours because I slept in that hospital overnight in the ICU for 2 months. I was there pretty much every night. And so that like relief of burden of having someone who was passionate and cared and wanted to help my father that I felt like I could trust was I couldn't have made it through without nurses like you, Em. So I just want you to know how grateful I am for you and what you do. And also just I think people are so appreciative. If you don't hear it enough, you need to know.
Um, yeah, I thank you for sharing your story. That's so powerful. And I'm really glad that he passed peacefully. I think that ultimately is what everyone wants. And that's what our goal is, in palliative care as well. Um, I I always say, you don't get to choose where you enter this world, right? But you can choose where you leave it. And Nobody wants to die in the hospital, right? Everyone wants to pass it home, surrounded by the people that they love, in a setting that's comfortable for them, and giving the patients the opportunity to do that. Fighting for them to make sure that like this is what they want. They don't want to be, they don't want all these life-saving measures, right? And having a patient and advocating for a patient and making sure that not just the providers but also their families understands this is um my biggest passion. um my best friend too, she does the same thing, and she'll ask patients, um well, she works with kids, so obviously the ones that are older, but how do you want your loved ones to see you when you're past, right? Like, no one wants to see. I can't, I don't know anyone that would answer that question, be like, I want to see my mom connected to all these tubes and whatnot, right? No, you want to see her as she is, right? As the person that and that you love, minus all these artificial um devices that are just keeping her heart beating, but maybe not, but nothing else. um so it's we have these conversations, right? We have to have these conversations with families and with patients and with providers, and it's not easy, but it's absolutely 100% necessary. And I love what I do, and I love doing that because it is, like I said, that's my biggest joy is having a patient being able to advocate for themselves and be like, I want to die home and I want to go in my own way, right? Not connected to tubes, not in the hospital. And I want to be, at home, in my final days. To the nurses out there who think that, they're not being heard, they're not being seen, patients and their families are seeing you. They are appreciating you for what you do. Whether or not it may not be in the hospital, I've been yelled at by plenty of family members, and plenty of patients, plenty of providers, and that's part of the job as well. Unfortunately, it comes with the territory, but you have to know that what you're doing is right. And whether or not you're not appreciated in the moment, once, because um, patients and families are, emotion is runs very high in the hospital, and rational thought is not exactly um, always present. But when it does, and when patients and families come to their senses, they are really genuinely appreciative.
Yeah, and I think that's why it's so important that awareness be risen on the fact of what palliative care is and that it exists and that it's an option for people and patients. Because I'm sure there's a lot of people out there who would take advantage of that opportunity to have that care if they only knew it existed. So I definitely think it's important that we shine a light on palliative care, what it is, and you, Em, who are a nurse who go through this on the daily and help patients.
Exactly. It's patients in my own institution, right? So we don't even call our department palliative care; it's supportive care. But at first I had an issue with that, but now honestly, it actually has done quite a, it's done a lot better, for patients, because they're less fearful um, to see us. But at the end of the day, they're like, yeah, like, is this, when I explain in the department, I obviously explain what palliative care is, but we call it supportive care. And then when patients are, asked, they're like, oh yeah, like, is this palliative care? I'm like, it is. And they're like, why don't you just call it that? I'm like, well, would you have come to us, if we had said palliative care? And a lot, 50% of the time patients are like, no. But they're also very grateful and thankful that they have been referred to us because, we help them. So, like, to patients that, and providers, let us help the patient, let us help you as a patient get through, some of the worst times of your life, right? And not just the patient, the family, the caregivers as well. We do a lot for the caregivers. And we want to make sure that, their burden is lessened as well. As you probably know, with your dad, being a caregiver to a patient with cancer is very difficult, and very difficult emotionally. And it's hard to be strong for two people,
Mm.
And that's, talking to both the caregiver and as a patient, right? So at the very least, let us help you unburden some of that, those emotions that you're dealing with, that you're struggling with, so that you don't have to carry it alone.
So beautifully said, Em. I okay, so I have to ask you, I want to segue a little bit into what did getting your first stethoscope, whatever stethoscope it was, what did that mean to you? Like, do you remember the moment when you got your first stethoscope?
Uh, yeah, actually I was like, my parents got it for me when I, before I started nursing school, and I wanted like the best one. I was like, I want to like be flashy about this, and I yeah, so I was like, I want to be all out. I go all out. I went to Duke for nursing school, and I knew that people would, they would be doing the same thing. But to me, and it'll be like it wasn't even more so getting the stethoscope, it was using it for the first time. And I'm like, wow, like this is like testing, you wear it all, you wear it everywhere you go, and you're like, I'm a nerd, right? But it it's like, listening to someone's heartbeat and like being like, okay, cool, like this is like what my job is going to be, right? This is how I'm going to identify, you know, an illness, right? It's a big step. Of course, I could, when you first listen, you have no idea. Like, you're like, okay, that's a heartbeat. Like, but you can't, that's all right? Like, you're like, oh, I could take a deep breath. Like, okay, cool. Like, I can see that you're breathing. But it's kind of, kind of validation that you're what you're there for, and what you're about, the field that you're about to step into. So it's a cool moment. I've done a couple giveaways with you guys, and it's always been popular because MDS stethoscopes are amazing. Just the amount of designs that you guys have alone, I think, exceeds any other stethoscope company out there, and it's fun. Like, right, when you want to customize your stethoscope, you want to make it your own, right? Because you know that you're going to be with this thing and for a long time, right? This is going to be like your right hand man when you're working. So yeah, always fun to partner with you guys. If you're a new nurse and you're struggling, right, just know that it's going to get better, right? And everyone may not start off in a role that they like, right? I loved my first job, but I knew that it was not what I was destined to do, right? And if you're questioning, your job, or your role, or your purpose, know that you'll find it, right? Everyone has a niche in nursing. And you'll find your niche, and once you do, you will find that passion, and you will excel, and you will love what you do, and you will find that drive to go to work every day and help your patients. And once you do that, it'll reflect in your patient care. It took me a couple years to find mine, but here I am doing what I love, and I'm trying to pass that message on to y'all.
I love that. And for everybody listening and watching, can you drop your social media handle so that everybody can come over and give you a follow and check out all the informative information you have on your page?
Is that Spitfire Nurse M? It's on Instagram. Come give me a follow. I post like goofy, somewhat educational, informative videos for every week. So come by.
It's so fun. Sometimes she's knocking out another doctor with the punch end. Sometimes she's dancing. She's always finding interesting ways to educate, entertain, and also give great advice. And you post some really great vulnerable things on there too. I saw the posting where you were going through and saying, social media isn't, it's a highlight reel. It's not all of it is glamorous. And you kind of showed the things that you shared, the struggles that you have personally. And I think it's really important that we all remember that, we're all human, we're all trying our best, and we have good days and bad days, and to be kind to each other and to ourselves.
Absolutely. I think nobody's perfect. And I knew I had to do that post because my social media, who you see on social media, is who I am in real life, right? I'm not, I made that a promise to myself when I started this page. And so, when that trend came up, I knew I had to post and, let people know, what I deal with, and how I manage it. And it's been touching. A lot of people have reached out and said, like, thank you for sharing. I deal with the same things. And that's what it's all about.
Yeah, and I think it makes everybody feel less alone when they see that you're struggling or going through the same kinds of things that they're going through. And it's like, oh, it's not just me. Because sometimes we can trick ourselves into thinking, oh, everybody seems to be knowing what they're doing. Everybody's life seems to be great. Like, what's wrong with me? Because people they don't have the tendency to share that as much. So I think it's a really great message to bring closeness, to have related be relatable, but also just to make people feel less alone in the world, who are going through, you know, maybe a similar career path as you, or even on the other end as a patient. Just knowing that like it's hard on both ends. It's hard for the patient, but it's also hard for the nurse. It's hard for the medical staff. It's hard for everybody because, you know, watching someone go through those things, it's no easy feat, and it takes a toll emotionally, mentally, and physically on, I think, on both sides.
No, 100%. I Yeah, it's tough to be vulnerable. But I owe it to my patients. I ask them to be vulnerable with me, and so it's if I'm not true to myself and I'm not, practicing what I preach, then, what am I doing, with my nursing career? Um, and I love that you bring up, not feeling alone, because, nursing is 100% a team-based profession. That's why I love nursing, right? You're only as strong as as your weakest link. And you can't save a life by yourself, right? So when an emergency happens, it's good to know that you have people around you. And the nursing community is so strong, and it's so large. And we have our own internal struggles, but I like to think that nurses will always support each other. When things happen, and when things happen in the hospital or at home, that you'll always have someone you would return um, to help you get through.
I love it. Well, thank you so much for joining our Crafting Wellness podcast. It's been such a pleasure having you on again. And please, for everyone listening and watching who want to go follow that Spitfire nurse, and check her out. I'm sure she's open to answer questions. You can DM her, and we'll drop her handle below here so you can also check her out. But thank you so much for being on today.
Thanks for having me, Brooke. It's always a pleasure.